Joining us this morning is a friend of mine for a long time. I'm trying to do this, Tina. Tina Stashevsky.
Yes.
Did I do it?
You did it.
First time in about 5 years.
A+.
Yeah, right. And we also have a new doctor at ACMC, Dr. Sanjay
Srivastava.
Srivastava?
Yeah, everyone just calls me by that first name.
Okay,
Yeah,
Sanjay?
it's much easier.
Okay, I'll do that.
Yeah.
Okay. So you're a new doctor, and tell us what you do at the hospital.
So I'm in pulmonary critical care. So we deal basically with the lungs, and then also on the inpatient side, we take care of the ICU patients, and also consults on the inpatient side. Anybody with respiratory issues.
Okay.
If they need additional help, then that's what I'm there for.
Okay, great. Do you live in Ashtabula?
No, I live in Paynesville.
Do you?
Yeah. When
Yeah.
I came out here, I met some of the doctors, and then he told me about moving out to Paynesville area. I went there in the summertime. I like that area a lot, so I live in Paynesville.
Good.
Yeah.
Good. It's a nice town.
Yeah.
I just went through there the other night.
Yeah.
Tina, your hospital is very well known for recruiting a lot of different doctors. I mean,
Yes.
it seems like you, in the last 2 or 3 years, I've interviewed a lot of the newer doctors, and you've been kind enough to bring them in. I think you deserve an A+ on that.
Well, I don't take the credit for it. It's the hard work of Janet Vettel, who's our physician recruiter.
Janet, yeah.
And then also the entire administrative team. What we often hear from the physicians who come in to kind of interview us as much as we're interviewing them is that it's that team that they're exposed to, and they see the commitment that we have to the community and to our patients, and they want to be part of that. And we're very fortunate that he chose us as much as we chose him.
Sure. Tell us about yourself before we get into some questions.
I grew up in the suburbs of Chicago.
Chicago.
Preschool and med school there.
Bulls fan?
A Bulls fan, Cubs fan, unfortunately. And I went to medical school at Rush, which is in Chicago. I come from a family of doctors. My mother is an OB/GYN doctor, and my brother and his wife are at University of Illinois at Chicago in academics. After I went to medical school, I went to training for medicine and residency at University of Kentucky in Lexington, and that was for 3 years. Then I worked 1 year as a hospitalist. And then I did my fellowship in pulmonary critical care, and I finished last June.
What about family here? Do you have?
No family here. Just me here. My family's still in Chicago.
Oh, okay.
Yeah.
Okay.
So I go back whenever I get a chance to see them.
Got you. So why did you choose Ashtabula to come to practice?
Well, I wanted to stay in the Midwest. When you're in fellowship, you get a lot of job offers out there. Sometimes it's just one or the other. Sometimes they just offer critical care. Sometimes they just offer pulmonary. At Ashtabula, they give me the opportunity to do both, which I think is important when you first get out of training, because you want to do both. As later on as you go through your career, then if you want to focus on one side more than the other, you can do that. But I think it's important at first when you get out to do as much exposure on both sides. Had a really good interview here. I liked everyone here. I also like the fact that it's affiliated with Cleveland Clinic as well.
Right.
Because I think that's important if you have a patient that sometimes it's beyond the resources of what you have at the hospital that you can refer to there, and you can still follow the patient still. And it's also still a learning opportunity for me to see how they do some things over there as well.
Excellent.
So yeah, it's been good here so far.
Very, very good. We welcome you for coming here. Maybe for those folks out there, I know you kind of talked about it a little bit, but maybe for the folks that might not understand some of the different things that you do with lung problems and lung disease and stuff like that.
Right. So basically with any breathing issue that you have, they can be referred so I can see them. The big things that we deal with are COPD, which is, as many people know, is related with smoking significantly. Asthma, yeah, is another thing. Any other sort of breathing issues as well, infectious pneumonias as well. Also, if a patient they find a lung mass or something unusual on their lungs, then it's our job to help try to figure out what that is through what we call bronchoscopes, putting a scope down either through the mouth or through the nose and taking a look at their lungs and see if we get a sample from there as well. But probably the majority of the patients, because of smoking, we're going to be dealing with a lot of COPD issues.
Right. Is this what you've always wanted to do?
Yeah, well, Part of it was my grandfather had bad COPD, so I think that had an impact on me as well. But I think another thing was, I think for a lot of us who go into pulmonary, it's the critical care side as well. When you're in training in residency, you work in the ICU, and that's where you do a lot of learning, because you have to learn how to prioritize the problems that the patients have. You have to be efficient, you have to be quick. You're dealing with the really sick patients as well. So that really changes your confidence level after that. And for most of us, I think through that experience and then doing things like vent management and things like that, it had a big effect on me. So I thought, this is the area that I want to focus on in medicine.
Sure. I had a brother-in-law that lives out in Arizona with
Yeah.
my sister, and he came down with something called sepsis or
Sepsis?
Yeah.
Septic shock?
Yeah.
Yeah.
And on top of that, got pneumonia.
Yeah.
And he was supposed to come home next week to go to his granddaughter's graduation, and it caused all kinds of problems because it was intent on going on. However, his doctor said, you can't fly.
Yeah.
You can't fly with that condition, so he's not coming back.
Yeah. Yeah.
So
The pneumonia could have been the start of that.
that can cause it.
Yeah, so I mean, we usually when you talk about sepsis, it's basically usually you think about infection throughout the body, and what you worry about is going to shock.
Really?
You're right, and it usually starts with some sort of underlying infection. Many times it's with a pneumonia or a urinary tract infection or something like that, and it can cause your body to shut down.
Really?
Yeah. So if you catch it early enough, that's the whole goal. Actually, that's what the idea is behind that. When the patient comes in, if they're unstable, to treat them as early as possible, to get them stabilized as early as possible, and that makes a significant difference in their.
See, I had never heard of it before.
Yeah.
Until he got this.
Right. It could be touch and go, but.
And it was, I guess.
It was right. So I understand where the doctor's coming from, saying that you need to. Slow down a bit, but the whole thing about that is treating it early. So if you have any sort of persistent infection, pneumonia, anything like that, even if it's not lung related and it's not going away, it's better to see a doctor and get it checked out, because you can prevent some long-term problems later on.
Doc, you mentioned COPD,
Yeah.
which I've had other doctors on here talk about it, but I never had them explain what actually that is.
Yeah. So basically, it's what stands for chronic obstructive pulmonary disease, and basically what it does is it affects your airflow. And with COPD, it causes inflammation in your smaller airways, and it can also. The other problem is it causes destruction of the actual lung tissue. And what happens is your lungs lose its ability to be elastic. And so what happens lots of times is with people with COPD, the way they present it is they have no problem taking breaths in, but they have a problem getting breaths out. That's the obstructive part, because their lungs don't recoil.
I got you.
You know what I mean? They take air and they trap air. And clinically, how you see it is like wheezing or coughing are examples. Now, with COPD, if you've had it severe enough, then it's permanent damage there to the lung. But that doesn't mean we still can't treat.
I was going to ask you about that.
Right.
What can you do?
Well, the main thing is you want to first figure out what's the cause, and usually most of the time it's smoking. So that's the big part when you're talking with patients is talk about how important stopping cigarette smoking is out there. You work them up, and then it's a matter of actually treating their breathing qualities. You can still improve their breathing functions through basically with inhalers.
Inhalers will do it?
Right. Usually start off with what we call albuterol, which is a bronchodilator, and it provides immediate relief for the patients when they take it. It doesn't last long, and depending on how often they have to use it, that's how you kind of determine whether or not you need to step up their medications with other inhalers. And those are other bronchodilators or like even inhaled steroids. The idea is to open up their lungs. But no matter what you do, if they're continuing to smoke or they're still exposed to secondhand smoking or anything like that, then you're limited in how much you can treat them. I always tell the patients, you got to treat yourself. This is part of the process here, and smoking is one of the hardest things to quit. But if you stop and you stop early enough, you can make a significant recovery in your lungs.
Excellent.
That's what I try to get across to the patients.
Well, you mentioned asthma too. Now, my son had asthma.
Yeah.
He seemed to outgrow it.
Yeah.
Is that possible?
Yeah, I had it too when I was a kid.
Really?
Yeah. Yeah. So asthma is also an obstructive process as well. It's also an inflammation of the lungs. But the difference between COPD and asthma is in general, asthma is reversible. Whereas with COPD, you can still improve lung function, but the damage is there to the lungs. It's always going to be there. With asthma, it's many times just inflammation in the lungs that can eventually calm down, or it's what we call bronchospasms, where the lungs tighten, but if you give a treatment, then it calms down and you go back to normal breathing.
Is that when you use an inhaler, when they tighten? Is that what that
Yeah,
is?
yeah, and that's that albuterol again. There's an overlap of treatment between asthma and COPD, but you always start usually with an albuterol inhaler,
Okay.
which opens up the lungs. And for many people, it's related with allergies too. That's the other thing. One thing about asthma that's important that I think people should know is one of the most important questions is trying to find out what the trigger cause is, because many times it's something that you're exposed to that induces it, and by simply getting rid of that factor, it can change your breathing pattern. But for a lot of people who have childhood asthma, as they get older, they outgrow it. I had to use an inhaler every once in a while when I was a kid. I haven't used an inhaler, a long time since then too. So that happens a lot.
You mentioned allergies, and this is the allergy season.
Yeah.
We're kicking in.
Yeah.
I don't know about you, Tina, but I've been sneezing, and
Yes.
and they're saying it's not that bad yet.
Imagine what it's going to be like
Yeah,
in a
really.
few weeks. Yes.
Maybe you don't deal with this, but do you practice anything with allergies?
Yeah, so I think it's important, and this is part of when you talk with the patient, you want to get their history and you want to know what they're exposed to, because once in a while that can actually change the way your treatment is. And even if it goes beyond what I cover, then my job is then to refer them to the allergy specialist, because they can also help. Sometimes it's not just what you're exposed to, but some people have immune deficiencies. They just don't have the defense mechanisms in their body to fight certain allergies, and so they actually need supplements like an infusion of what we call immunoglobulins, things like that.
Good.
So then, if I can start to spot that, then I can refer them to the allergy specialist to help them. If I can't, if it's going beyond my scope of treating that, but a lot of this it's all related, especially with asthma. So I can do the initial workup to see if that's what's going on here. And
I had no idea that.
Yeah.
Wow, that's amazing. Yeah, he had it pretty bad, and he had to carry an inhaler. I remember when he walked to school.
Yeah,
sometimes.
it's what you call a rescue inhaler, and that's what you try to stress to people, is that you're supposed to keep it with you at all times, because it's easy to use. One important thing also for people, especially in kids who are in sports and they have asthma, sometimes that you're going to do a certain event or something that's going to cause it, you actually can take it beforehand and be assertive about it, and that's a way of preventing the symptoms from occurring as well. Yeah. A lot of kids are shy about using their inhalers, but we try to get across them that it only takes a couple of seconds to do, and then the relief is pretty quick.
Yeah.
So anybody who has that, the whole point of it is to have it with you, because it works quickly.
You might be too young to know this word that I grew up on as a kid. My mother always says, it sounds like you have the croup.
Yeah.
Have you heard of that?
Yeah.
What is that?
Croup is actually it's a cough. I think it's kind of a little bit of an outdated term, but it's important because cough can also be related to asthma as well.
Oh.
Yeah, sometimes people can present with a cough, and it's called cough variant asthma. So it's actually a form of asthma, but they don't have the typical wheezing patterns that
Right.
but they have a cough. And you treat it the same way you treat asthma. Okay. So that's a big part of. I get a lot of patients who have come in with persistent coughs as well, and you want to figure out what the problem is. And many times it's a respiratory issue, but then you also want to look at other things as well. Reflux, heartburn can cause cough.
Really?
Yeah. Actually, I have that too, and so sometimes that's where the problem is. It's not always the lung issue as well. So it's related to the respiratory.
Too.
Yeah, and then it's related with allergies as well. Sometimes it's above what I do. Sometimes it is related to more the upper airway, and that's where the ear, nose, and throat doctors can help out if there's something going on there. Sometimes it's their vocal cords, if they have a problem with their muscles in that area, that can cause cough as well.
What about bronchitis? Very common around here, it seems.
Yeah. So bronchitis is inflammation of the smaller airways in your lungs. People who smoke are more prone to get it. Basically, I'm going to tell everyone, if you smoke, you're going to get bronchitis at least a couple times a year.
Really?
Yeah. Because what happens is it's inflamed, and easy for your lungs to get infected at that point.
Mm-hmm.
Also, you get mucus production. It gets very thick, and it gets hard to get rid of too as well. Normally, lots of times bronchitis is viral, so lots of times it's just supportive treatment.
And viral, so it's catchy?
It can catch, but it doesn't last long. But the thing about it is, lots of times antibiotics don't work right. So that's why you don't start antibiotics right away necessarily when a person has bronchitis, because lots of times it's viral. So if it's viral, then you don't treat it with antibiotics. Now, if it persists, it's not going away. That's when you start to think that maybe it's a bacterial infection. Then you treat it with antibiotics. So initially, it's supportive care. You treat the breathing issues that they have.
Okay.
If it persists longer than that, then you start thinking that this could be something not viral. It could be a bacterial thing, and then you get more aggressive with your medications, and you start treating with antibiotics. But sometimes I think people sometimes get treated too early with antibiotics when it's a viral infection, so it's not going to help.
That doesn't work.
And all you're doing is actually you're just introducing resistance to those antibiotics because it's not treating it.
Okay, very good, very good, very interesting stuff here. That I was not aware of a lot of this stuff, so it's very interesting to me. Before I go on just a second here, I have a couple more questions, but Tina, I want to get back to you.
Sure.
I know you've always got something, your plate's always full at ACMC. Well, you got anything new coming up? Or
well,
anything?
actually, one of the reasons that we wanted to get Dr. Srivastava on the show was to introduce him, person to person to the Conneaut community, because he is going to begin seeing patients here at the Conneaut Family Health Center.
Really?
At the end of the month, on a once a week or
I think it's going to be every couple Fridays.
So we know that upper respiratory illnesses are pretty prevalent in the Conneaut area.
Very.
So it was important for us to bring him out here as one of the first specialists that we put through the Conneaut Family Health Center.
So they will be able to make appointments for that?
Yes.
Now,
Still calling the Ashtabula number, but you will then be able to schedule either in his Ashtabula office or in the Conneaut office.
Okay, that is where Dr. Rufa is
Correct.
located,
Yes.
up on the west end.
Yes.
So that's where Dr. Sanjay will be there. And you'll let us know probably the days.
Actually, you probably can start calling now to schedule.
Okay.
with him.
And you'll let me know when the
Yes.
actual day will
Yes,
be.
I will.
And times and all that sort of
Yes.
stuff. That way I can announce it here
Sure.
on the show. So I think I've learned about everything I can learn about pulmonary problems here. You definitely, with the bottom line is smoking is a no-no. You don't want to smoke.
Oh yeah, I mean not just we've been focusing on COPD and breathing, but also lung cancer.
Yeah.
And that's part of my job too. Sometimes a person comes in and they get a chest X-ray for something else, and they see a mass, and then we have to work it up, and then you do the scope, and you get a piece of tissue, and it comes back as cancer, and then you got to tell the patients that, and then you got to work that up too as well. So it's not just a breathing issue; it's also lung cancer, which is on the rise.
Absolutely. Yeah.
It's a generational thing. I think that it's all about education. I think my parents' generation, they grew up with smoking.
Mm-hmm.
I think over the last 20 years, people are finally starting to realize just the significance behind it, and hopefully that that can continue, and you let the younger generation know that don't even start, because once you start, then it's very hard to quit.
I think it was in the early '60s when my dad used to smoke Viceroy. I think it was Viceroy cigarettes, and it came out in '62 or '3, I think, that smoking was not good for you. He quit immediately that day, and never smoked again.
My dad quit cold turkey after what happened to his dad, my grandfather.
Yeah.
Right. It scared him.
Sure.
But it just tells you how tough it is. I mean, people out there who can barely breathe, and they know the risk for lung cancer, and they still can't stop. It just tells you the vice that it has on you. So, the best advice is not to start.
I've actually seen people smoking while they're on oxygen.
Yeah.
That's so scary.
It is. Yeah, you're at risk. Actually, in the hospital, I've seen it happen where a guy tried to sneak a cigarette while he was on oxygen, and he burned himself.
Did he really?
Yeah.
That's very dangerous.
Oh yeah.
In more ways.
It's not always just smoking; it's also secondhand smoking. That's also important to point out.
Yeah, talk to us about that.
You can get respiratory diseases from just secondhand smoking.
Like if a spouse smokes and you die.
Right. But we always tell people if you're a couple and they both smoke, the best way to quit is together.
Together, I heard that.
Yeah, because you want to take the temptations away, and you have to be, and if you have any lung issues, then you have to be aggressive, and you have to tell people you can't smoke around me. You have to put your foot down and say that you can't do that.
Right.
Not only for the temptation, but for your own health as well.
Right.
But in third world countries, it's not even cigarette smoking. If it's bad ventilation systems and the way they cook, biomass fuels, things like that, you can get COPD as well. So the one thing that we point out about COPD is that it's preventable. This is something that if we stay on top of it, we can lower the incidence to it.
You're getting a phone call here. Let's see, we'll take this real quick. Hi, you're on the air.
Hi, Pat.
Hi.
I know that COPD comes from chemicals as well as smoking. And Ashtabula County is bad for air quality. In the recent days, we've had a smell in the area that chemicals. And I'm hoping that Ashtabula County Medical Center and the medical centers here will start an initiative more for prevention than just treatment, because we need to do this to eliminate this problem.
Okay.
And so I'm hoping that they will work to improve air quality and work towards that, as well as treatment in the area. Because there's a real problem here, but no one is addressing it.
Okay. Okay. Hey,
So-
is this Judy?
Yes, and I know because I went to treatment and I was treated for COPD.
Oh, okay. Okay. Hey, Judy, Debbie
Yeah.
Newcomb wants you to call her.
Oh, I have her email. I'll just email her.
Yeah, she's got something for you.
That'll be great.
Okay, Judy.
Thanks so much.
Thank you.
Good
Bye-bye.
that you have the doctor there to address this. Thanks.
Okay.
Bye-bye.
Bye-bye.
Well, that's an important part, because one part of your history when you're talking with a patient is you want to get their occupational history or their living environment history as well, because if that is a problem, then we can help address that issue or point that out, saying that we think that this might be the cause of what's going on with the patient. And I guess the question then, because it may go beyond my scope, then is are the facilities doing everything they can to protect the workers and the people in that environment, as far as ventilation, if it's work related, are they having proper masks and things like that as well?
Sure.
It's not just COPD as well. It's also more industrial type of work, construction, coal mine workers, things like that. They can also be, over a long period of time, exposure. Fiberglass, they can develop fibrosis, which is hardening of the lungs, which is restriction, and cause scarring in the lungs as well. So it's not always just COPD. So it's always important to know what their occupation is, and if their employees doing all the things appropriate from to protect the workers and the people around there as well.
Did you say cystic fibrosis?
Fibrosis, pulmonary fibrosis.
Okay.
Cystic fibrosis is something that you develop when as a kid.
As a kid, I've heard kids get.
Thick mucus production. You can have what we call emphysema, dilated aerospace disease. It's a genetic thing. Also, you can have some issues with your pancreas as well. That's a genetic. What I was talking about more pulmonary fibrosis, where this is hardening of the lungs. Lots of times when you look at a CAT scan, really progressive fibrosis looks like honeycombing on the lungs.
Really?
Yeah. Sometimes it's genetic. Sometimes it's related to other health diseases like rheumatoid arthritis or autoimmune disease. But also sometimes it can be related to work exposure, fiberglass, coal mine workers, things like that. What's called like coal miners' pneumoconiosis. You can develop hardening of the lungs over a period of time. We see that especially, my parents' generation, because they didn't wear masks and everything like that when they went down there and they worked and they were exposed for years and years and years. And then eventually it took a toll on their lungs. If you have fibrosis, that's permanent damage there. The goal in that situation is you try to do everything you can to prevent it from getting worse. And those are things like heartburn, reflux, that can make your lungs worse, because basically, or aspiration, where if you have trouble eating and you cough and you choke, that means part of some of those food particles going down into the lungs. Those are things you can prevent to help to not progress the fibrosis, because any sort of insult, you want to stop any insult to the lungs. You want to keep it where it's at and not let it get any worse as well.
There's something on television all the time about well, it's lawyers trying to get business, but something that is dealt with asbestos.
Yeah.
And there's a name for this disease, and I don't remember.
Mesothelioma?
Yes.
Yeah.
That's it.
Well, it's not always connected, but it can be connected. The problem with asbestos is that people don't see the results of that exposure till 20, 30 years later. But they're two separate things. Mesothelioma is actually lung cancer, whereas asbestos is calcification around the lungs area, and it can cause restriction in your breathing capacity.
Mm-hmm.
I think part of it is just the fact that it took time for us to understand this, because people don't get it right away. People don't get the symptoms right away. It's 20, 30 years later that we finally realize. So it's a delay effect. Now we know a lot more about it. So as far as roofing and insulation, like, we know what to do now.
Right.
Whereas in the past, we didn't know about it because we didn't see the effects till 20, 30 years later.
Sure.
Now we're seeing the effects, from it. So I think that was the biggest problem with that.
I had a friend that died of that.
Yeah.
He was a fireman, and
Yeah.
I guess it was something to do with his helmets or something that he wore way back in the
Yeah.
50s and 60s.
Yeah.
And like you say, it took a long time for it to come on.
Right.
Yeah. Well, I know you're going to be probably busy. I know all winter long we had so many people sick with colds and,
Same here.
you know.
I got sick too.
You did too?
Oh yeah.
Oh boy. Yeah, we had a bad winter
Yeah.
here. We probably were here for it. So,
Oh, yeah.
So, Tina, anything else?
We have a program coming up for students in 7th through 12th grade this summer. It's called Bridge to Fitness, and it is about them helping to develop healthy lifestyles. So they can call Premier Fitness at 998-3488. It's 998-FIT, and find out more about that program. It is completely free. I believe it runs for 4 weeks, maybe 6 weeks. It's twice a week, open to the parents for participation as well. Because
Wow.
the best way to make healthy lifestyle changes is for the whole family to do it.
Great.
So that's something else I wanted to let the community know about.
Okay. And then you'll let me know when Doc's
Yes,
up.
I'll call in with the official dates.
Great. Thank you, Tina. Doc, nice meeting you.
Nice meeting you too.
Very, very educational set.